Right. It's mid-afternoon in the beautiful Swiss area. It is 1 p.m. here, and somewhere it's 3 o'clock in the morning, which is usually gin time. So wherever you are in the world, good afternoon, good morning, good evening. Thank you so much for joining us. It is the first Q&A of 2024. And we thought we would start with somebody handsome, debonair, young, exuberant, intelligent, but he wasn't available, so we've got Andreas. So
I apologize for that, but also a warm welcome in this new year 2024.
So thank you. Good to see you. So we were just talking before we went live. Very much looking forward to the next summit, which will be hosted in April. And Andreas has said that he is joining us there as part of our medical advisory board, which we're absolutely delighted about. So we will welcome your questions about that all day. So as ever, we have some questions already sent in, which we would love to have answered. The one caveat that we have today is that this is about general medical information, and it's not about personalized medical advice. However, we will do the very best we can to answer your questions and to do what we can to help you in terms of your next appointment. So again, we're not here to take the place of your next appointment with your consultant, but what we're trying to do is inform and empower that conversation. So Andreas, it's good to see you, my friend. How are you keeping?
Thank you very much. I had a lovely start into this new year, and I'm very much looking forward to these further collaborations and the Q&A webinars you're hosting.
Good. Okay. Thank you.
Thank you for having me.
So the last time we did this, you actually had an emergency in the hospital.
Right.
So I'm scared to ask, but I do hope.
No, this person, we are very lucky, but he's still alive.
Wonderful.
And
right.
So we are still taking care of him, but at the moment, it looks much better than at that time.
Fantastic. That's great to hear, and I'm grateful for that. So thank you very much. See, not only does Andreas know stuff, he does stuff as well. So, which is fantastic. Right, Andreas, here we go. We've got some questions for you. So if we may, let's get started and see what we can do. So here's a couple of questions. Somebody's AMA has improved in the sense that it's gone down. I don't actually know if that's an improvement or not, but they've just looked at the FAQs in the PBC Foundation app, and they noticed that a lower reading or even no reading of AMA doesn't actually mean that you don't have PBC. Can you elaborate on this?
Yes. I personally tell all my patients that the AMA antibodies are only used for the diagnosis. We even do not do follow-up investigations except for specific reasons where we are not sure about diagnosis or want to repeat something if we have very low titers. Otherwise, an increased alkaline phosphatase with this autoantibody is sufficient for the diagnosis. It does not has to be followed up. It doesn't mean anything. There is no data illustrating to us that changes in this titer has any meaning. So whether it goes up or it goes down, this doesn't tell you whether the disease progresses or regresses. I wouldn't interpret these data.
Okay, thank you very much. Here's my question for the year. I'm going to ask every single clinician that I work with this question. Antimitochondrial antibody. Mitochondria is the energy, is the battery within your cell. PBC fatigue, which brings us back to antimitochondrial antibody. Does the AMA titer give you any indication about fatigue in PBC?
No. So I don't see any clear-cut data on antibody titer levels and the symptom burden. And I fully agree that we have a disease where mitochondrial antigens are presented and detected by the immune system. However, the height has nothing to do with fatigue, and we see many other conditions associated with fatigue, many other hepatobiliary diseases which are associated with fatigue, with exhaustion. So in that regard, there is no clear-cut correlation. We know that in PBC, in the very early disease stages, fatigue can be dramatic, which is uncommon in other hepatobiliary diseases, which are not associated with an antimitochondrial antibody, but otherwise, this is common in, seen in many also immune-mediated diseases, which are not having antibodies or T cells, immune cells recognizing antigens or small protein particles of mitochondria. So the energy trucks in our cells.
Okay, it was worth a shot. Okay, thank you for that. You've burst my balloon already. It's only January. Right, we will keep trying. Okay, we've got a question about intermittent fasting. So, we've got somebody who's doing relatively well with their PBC. They still, however, get some hot flushes, still sometimes feel faint and still tired, which they put down to the fatigue. Now, these symptoms appear when they're fasting or when they're not fasting. But do we know if intermittent fasting has any impact on PBC or on the symptoms of PBC?
This has never been investigated in detail. I think that intermittent fasting is something which is certainly of value for a lot of people, in particular for those people who have, in addition, a fatty liver disease. And these days, roughly every third inhabitant of a country in the Western world suffers from fatty liver disease. And once we perform intermittent fasting, then this fat from the liver is mobilized, is metabolized, disappears from the liver, and the liver doesn't like 2 or 3 bad conditions at a time. So if you already have a PBC and on top of that a fatty liver disease, which is now called steatotic liver disease, if you receive the letter of your consultant or gastroenterologist or hepatologist, this is the same. It's really the same. It's just a name change. These fatty livers on top of another existing disease, whatever it is, it's not necessarily PBC, it can be any other liver disease, and it is a second hit, a second driver for inflammation, for the risk of for fibrosis, for scarring of the liver. So this is certainly helpful. It has, whether it has a benefit on symptom burden, on fatigue, on itching, on arthralgia, or anything like this. To my knowledge, this has not been investigated. Would be worthwhile doing so. If you have a cirrhotic liver, you should be very careful with that. I would not recommend to perform this intermittent fasting, because every fasting means that muscle tissue is metabolized, because the liver cannot stand a long-lasting fasting period and then starts getting energy out of the muscle. This is muscle wasting, sarcopenia called in the medical jargon, and I would not recommend to do that. So this would be a situation where I would say, no, this is not a good idea.
Okay, perfect. Thank you. Okay, next question. CRP. I have no idea what CRP is, but somebody has
C-reactive protein, and
Okay.
this is a marker for inflammation in the body.
Okay. And is that all it is? It's just a general marker of inflammation?
Yeah, very unspecific. It can mean a lot of things, and also sometimes we see slight increases for whatever. It's produced by the liver, CRP. So if you have a very, very cirrhotic liver, for example, you may have a significant or severe infection and the liver does not produce any more CRP. This can then be a misleading situation in the clinical situation. But normally it just tells us there is some kind of inflammation. It could be, a real respiratory infection, but it can also be a hematoma after, a small accident you've had, or if you have done too much sports, or you have a vasculitis, or anything. It can be immune mediated. It can be by bacteria, fungus, viruses, whatever. Many, many causes.
Okay. And what about if you hit yourself with your car door putting a bike on the?
No, but I mean, this is interesting because hematomas, if they are large, of course, you need a significant hematoma. They produce a lot of CRP. They produce a lot of local inflammation. We see a colorful picture on our skin. This doesn't look too attractive, but this causes a lot of inflammation locally there.
Okay, so we're talking about bruising. Okay, perfect. Thank you. Right. I was diagnosed back in 2015. I weigh 11 stone 10 ounces. Do you need to know what that is in kilos?
No.
Okay, perfect. I'm on 1,000 units of urso. I have been advised to lose weight, which I'm finding difficult to do. I'm also on thyroxine for underactive thyroid.
Mm-hmm.
So the question is about an enlarged stomach. Is this what is known as liver belly, and what does that actually mean? So I've never heard the term liver belly before. So any thoughts on what this person can ask of their consultant, or any information we can give them?
So, I mean, for the 1,000 milligram urso for PBC, it's very likely that this is sufficient in regard to a normal regular body weight of, let's say, 70 kilograms. Now, we say roughly 13 to 15 milligram per kilogram body weight. So if a person weighs 100 kilogram, then I would rather go to 2,250, 1,500 milligram or so. So this could be adapted, maybe depending on the body weight. The thyroid function, I think, is very important for losing body weight. So it would be very important to clearly ask whether the thyroid stimulating hormone, TSH, whether this is in the good range, in the normal range, rather a little bit in the lower range, and whether the peripheral hormones are okay under this thyroxine supplementation. Because if our thyroid, this is the driver of everything in our human body, if that one is not adequately working and we have too low levels of these thyroid hormones, then we will gain weight and we cannot really lose weight. So this needs to be adapted potentially. And then losing weight is something which is difficult. There are 2 or 3 major things I always say. When we do more sports, this is often not resulting in losing body weight. So losing body weight is much easier done by eating less. Because when we do sports, this is healthy, this is good, no doubt. But we are way more hungry after moving, whether it's swimming, cycling, walking, whatever. And then on top of that, we say, we have been outside, we have been now walking for 2 hours, and then I'm allowed to eat something extra. And this is, of course, this is a psychological phenomenon. Everybody knows by himself. For me, that's the same. And the problem is losing body weight is much easier with interval fasting, for example. And in that regard, interval fasting, meaning 8-16, during 8 hours of a day, you're allowed to eat something, and the other 16, you shouldn't eat something, and you should only use calorie-free drinks. That is the positive list for my patients is water and unsweetened tea or coffee. And that's it, and nothing else. And that helps a lot. And on top of that, the second recommendation I always have is that you should chew at least 30 times per bite, because this tells our brain, okay, look, nutrition is arriving. And a lot of things are already, of these glucose amino acids are already taken up within the mouse. And that gives us the feeling that we are satisfied earlier. If we eat very rapidly, everything goes into the stomach and we still feel hungry or not, let's say, satisfied with the amount we have had. So the more time you take, normally you are as satisfied with 20% less on your plate. And the third thing I always tell is to reduce carbohydrates, because carbohydrates, whatever it is, do not only think about sweet things. I mean, it's obvious, a piece of cake or sweet things, chocolate, but also think about the slowly um, uh, taken up carbohydrates, such as potatoes, such as spaghetti, pasta, and of course bread, and all these issues. They will release insulin, and once insulin goes up, we are unable to lose weight, because insulin will tell all our fat cells store something inside, and then of course this doesn't work. So we can only lose weight when insulin levels are low, and insulin is low when we eat less, and in particular less carbohydrates.
Okay,
And
perfect.
the large stomach, a large stomach, I think this is not a clinical diagnosis, very difficult to interpret. And what was that? The liver belly? I'm not familiar with this term, I have to admit. So I wouldn't overinterpret this. I think there are not really large or small stomachs. In that regard, I think this is, I would say it's somewhat an overinterpretation.
Okay, perfect. Thank you very much. Here's a question. Can an IGM help distinguish between fatty liver, now steatotic liver disease, and PBC, now PBC?
No, I know. I mean, it cannot. It's purely a hint towards PBC. We know that in PBC, polyclonal IgM antibodies are present in a significant amount, meaning that the cutoff values are normally exceeded. So this value is abnormal. When you draw blood and examine that, it's useful to then look specifically whether a PBC is present. So if you say, I would like to have a very cheap screening initially, I can recommend to do IgG for autoimmune hepatitis. IgM hints more towards PBC, but it's not helpful to make a diagnosis. It's just a hint, and the hint should go towards then specific autoantibody, the investigation analyses, and otherwise it doesn't tell us a lot. Also, fluctuations, changes in IgM are not correlated to disease stage or improvement under a certain therapy.
Okay, perfect. Thank you. So if you have fatty liver or steatotic liver disease, your AMA is positive and your ALP is mildly elevated, is it helpful to do the IgM test?
No, it's not helpful. It doesn't tell you, it doesn't give you any additional information. If you have a slightly increased alkaline phosphatase and the presence of antimitochondrial antibodies, in particular, then the more specific antimitochondrial M2, then the diagnosis of PBC is made. You do not need any additional information.
Okay. And last question on IgM, can it also be detected in other autoimmune conditions such as Hashimoto's?
No, typically not. There are other conditions, but this is quite, in particular for liver diseases, this is quite typical associated with PBC. We do not really understand why this is the case. And in contrast, for example, for another immune-mediated disease, the autoimmune hepatitis, why their IgG levels go up, we don't know that. We do not have understood this difference, this pathophysiological mechanism behind that. It's just an indicator.
Yeah. Okay. Thank you. Now, if you've asked this question, first off, thank you very much. Because the question is, I have PBC and I'm running a half marathon in March for the PBC Foundation. So thank you very much for doing that.
Wonderful.
The question is, every time I go for a run, I get runner's diarrhea. Can I take Imodium before each time I go for a run?
Regarding the liver disease or so, I say there is no limitation to Imodium. Whether this in the end really helps has to be tested. I think it's no. I have no problem taking that and give it a try. If it works, why not?
Okay, perfect, ideal. Thank you. Next question is about kombucha, if that's the right word for it. I've read that kombucha, or Kombucha, kombucha, contains small amounts of alcohol from the fermentation process. Is it okay for those with liver conditions to drink? And if so, would there be a suggested limit for the consumption?
So I tell you what, with all these things, which are most likely from certain plants derived and so on, the fear as a hepatologist I always have is that these plant extracts and so on are very undefined and have a significant risk for drug-induced liver injury. And the small amounts of alcohol which are associated with it, that is normally not an issue if you don't drink the whole bottle a day normally. It's rather that the definition is that all these plant extracts, whatever it is, are not tested for security and safety. They have not been investigated for efficacy. And on top of that, normally the requirements are that at least 50% of a certain substance must be in such a bottle, pill, capsule, or whatever it is. That means that you take something which has never been tested for safety, neither for efficacy, and you do not even know that best 50% needs to be in there. This is the issue about it. If a person has the feeling that this helps me a lot and it doesn't harm the liver values, I say you can continue with that, but otherwise I would rather save the money and do something else with it.
Okay, perfect. All right, thank you very much. That's helpful. I am 72 years old. I know, I don't look it. I have PBC with cirrhosis, compensated, diagnosed 3 years ago, and taking Urso daily. I had a stomach ache, which turned into a GI bleed, and then my bowels totally released with blood, and I passed out in the hospital. So, any idea what could cause this? The doctor said it was possibly some form of colitis. They've never had it before and are obviously a little concerned. So any information you may have would be helpful.
Well, the issue is there. I have not fully understood that. So the bleeding was in the stomach, or where was that from? Because a colitis could of course cause a GI bleeding, but if you have compensated cirrhosis, I mean, the more important part would be, where was the bleeding located? And were there any signs of portal hypertension? Because portal hypertension means that the blood flow from the gut via the liver to the heart is altered by the cirrhotic liver, and the blood doesn't flow anymore as smoothly through the liver due to all the scarring tissue. And
Yeah.
the blood is like a river. When there is more pressure in it, more water, more blood, then it just looks for new roads. And a new road are these, varices which can occur in the esophagus, in the stomach, but also in the colon or rectum.
Yeah.
So, and elsewhere. So, if that is the case, I mean, this would be for me very important to know. If that is not the case, then many other causes are there for a GI bleeding. Most commonly, there are ulcera in the stomach or in the early part of the small intestine, the so-called duodenum, and
Yeah.
they are caused by bacteria such as Helicobacter pylori that can be treated by many, chemical issues. If you take too much NSARs, if you take some steroids or whatever, this can cause it. But also, stress, a lot of coffee, smoking, and just psychical stress can cause these ulcera. So there are many causes of that. And then they are further down in the colon. There are many reasons why we have a GI bleeding without any liver disease, without any portal hypertension. It can be angiodysplasia, it can be hemorrhoids, whatever. This would be, important to know what is really the cause. And then I would say, if the portal hypertension is excluded, then it has nothing to do with, most likely nothing to do with the PBC, and the cirrhotic PBC should be very carefully followed up. It's always important to think, do we need, for example, second line therapies in such an advanced disease stage? If
Yeah.
it's a compensated, stable cirrhosis, which has never been decompensated in the past, I would be very much supporting a second line therapy, just to ensure that the disease is not advancing. That would be my recommendation. Look for bone density, take a lot of vitamin D, and do a lot of, surrounding and optimization. And on top of that, in a cirrhotic liver, every 6 months, a sonography should be performed.
Okay. Perfect. Thank you. Comprehensive answer. Thank you so much. Delighted. So, right. So you mentioned second line therapy. So we know that when you're diagnosed with PBC, the doctor, hopefully on that day one, will prescribe you with ursodeoxycholic acid. First question: is it okay for GPs to prescribe urso?
Sure,
Or okay,
sure. Everybody should prescribe, and I always recommend, if the diagnosis is made, start as early. I don't say it's a drug, it's a supplementation of a substance which is already in our bodies. We just augment
yep,
and increase this bile acid. And for me, it doesn't matter who prescribes it. Everybody can do so.
okay, perfect. So thank you. And then even so, if you do normalize your blood counts, that's good.
That's
If you
wonderful.
don't normalize your blood counts, but they're still coming down, has the urso made a difference? And what should we do next?
It depends a little bit on, the original height. So
Okay.
if you start with an alkaline phosphatase of 900 units and it comes down to 600, then this is good, but this is not sufficient. If we start at, let's say, 300 and we are now with 130, but it's not normalized, this is okay. And I would say, it depends on additional factors whether a second line therapy may make sense, but it could also well be that depending on age and other issues, this is
Yep.
absolutely sufficient. So this is making the difference. So if it comes down, that's good. And we know that even after a year of this therapy, alkaline phosphatase and other liver values can come down in time, but the strongest improvement is always seen within the first 3 months normally. And then think always about, is the dosing correct? This is very important. Take your body weight and the dose you have of urso, divide the urso dose by your body weight, and you should end up somewhere in this range of 13 to 15 milligram. Whether it's now 12.5 or 16 doesn't matter, but it should not be 9.5 or 20.
Yeah. Okay, perfect. Thank you. And in terms of the other medications that are available, we have obeticholic acid, which is licensed, but we also have other options available as well. So what's the best question that patients should be asking?
I think the very important question is, do I need a second line therapy? You know, as an educated patient, you know they are available. You have obeticholic acid, as you said, as an in-label drug, which I think has the charming effect that it has proven to reduce scar tissue, fibrosis in the liver. And I think this cannot be, you know, valued enough, because the scar tissue in the liver is the driver for the need of liver transplantation, for the development of cirrhosis, for mortality, and so on. So the less fibrosis we have, the better we do, and the better the PBC will run. For all other therapies, this has not been proven. Still, there are many reasons why maybe obeticholic acid could not be the ideal situation, as for example, when you have significant pruritus. If you have pruritus which is moderate to severe, it should be treated first. So always, and this is the second question you should ask to your patient, or first to yourself, do I suffer from symptoms? Do I suffer from fatigue, from pruritus? Please, the next time you go to your physician, to your hepatologist, gastroenterologist, tell them, I have this and this symptom. What can we do about it? And in that regard, we have a lot of off-label drugs, and one off-label drug to treat pruritus and the underlying disease are fibrates. In particular, bezafibrate has good results there. And so it depends a little bit, you know, which drug should be taken. On top, it should be noted that there are novel drugs on the horizon. So the very near future will bring us further treatment options, which is great.
Yeah.
And many other drugs are currently in development, are in clinical trials investigated. And I think in that regard, we really have a very bright situation. When we look back 10 years ago, we only had urso, and now we have so much more. And this has resulted in so much more clinical investigations in research to better understand who will have the most benefit by what additional therapy, how can we optimize symptom burden, how can we treat that. So in the near future, we will have more and more also maybe dedicated drugs to treat only the symptom burden, which may not have a significant influence on the liver disease, but you will feel much better. So this is of hope for our patients. And so it's important always to ask, do I need a second line therapy, and can we do anything, if necessary, of course, about my symptom burden? And it's better to actively address that rather than wait for a potential question.
Yeah. Okay, perfect. Thank you. That's helpful. Okay. Symptom burden. Now, you and I have done a lot of work on this in terms of the pruritus or the itch or the fatigue. And we talk often about joint pain and bone pain and that kind of thing. The first thing I would say before I ask my question to you is that I would say to any patient who is going through a particularly symptomatic phase, and you can talk about how the symptoms come and go and that kind of thing. I'd love to hear your thoughts. But if you are going through a really tough time at the moment, whether it's itch or the fatigue, or anything at all with your PBC, that you're always welcome to arrange a call with us. Now, if you're in the UK, we can use the phone, but if you're out with the UK, we can use WhatsApp, Skype, Zoom, Click Meeting, Teams, etc., etc. So, other facilities are available. So what I'm saying to you is that if this is you and you are struggling right now, do please come and talk to us. Do give us a call. Let's arrange a time to talk. Talk to one of our trained professional staff, and let's see how we can help you in your PBC journey. So, with all of that said, what can you tell us, Andreas, about symptom burden and how you can support patients in their journey with that?
Yeah, I think every patient has to reflect that the time with the GP, with the whatever internal physician, gastroenterologist, hepatologist, is very much limited. And in particular, if you have a quite good treatment response, no physician will, or let's say the vast majority of physicians will not ask you for anything around symptom burden, because we are trained to focus on an underlying disease much more than on symptom burden. And in that regard, it's very important to address that actively, to illustrate, look, I have arthralgia, and this arthralgia is annoying and needs to be clarified. Arthralgia can be due to PBC, just as a additional, extrahepatic manifestation, meaning that there is some kind of immune reaction outside the liver going on. As we know, for the Zika syndrome, the dry eyes, the dry mouth, this is also caused by immune reactions in these glands here, which are around, the eyes, here the mouth, which are relevant to produce saliva. And if the immune inflammation is also present there, then the function is not properly working. We get dry eyes. This can be very distressing, and can be treated. And if you do not actively tell that, if it's not a very dedicated specialist, we will not come up with that. But this can make your life so much more valuable and enjoyable if you have less trouble from arthralgia, from Zika syndrome, from other symptoms, pruritus, and so on. This is something. And if the physician then answers, "Oh, I have no idea," or turns it around, is not very important for you, then you should ask whether it would be possible to get a referral to an expert center, to a whatever large hepatology unit where this could be addressed. And you could carefully ask for that. Do you know, is there any other expert who might help in this issue? You don't blame the physician. You can say, there are many thousands of rare diseases, but maybe there is some specialist which could give us somewhat more insights and tips and tricks what could be done. And then you don't blame your treating physician with that, because I also tell my general practitioners, I'm well aware there are more than 8,000 rare diseases. How can you nobody can cope with the detailed amount we know of all of these disorders. So it's only fair to get support by a specialist in such a situation.
Yeah. Okay. Perfect. Thank you. I know this question comes up a lot, but in terms of symptom burden and disease progression, can you talk about the lack of link between the two, if that makes sense?
Sorry, the lack of what?
The link. So the
Between
fact that your symptoms are getting worse, or if you're going through a particularly itchy phase,
yeah.
that doesn't necessarily mean that your bloods have to have changed, or there has to
Oh,
be disease
yeah.
progression, or can you
Yeah.
talk a little about that, please?
Sure. I mean, this is what I said initially. In PBC, we have a lot of patients who have strong and significant symptoms already before the diagnosis is made,
Mhm.
or at very early disease stages. And this doesn't tell my disease is very much advanced, or I have a liver cirrhosis or advanced fibrosis. No, this is not the case. It can fluctuate spontaneously, these symptoms, despite the fact that the disease is very, very stable. The problem is we have not adequately understood the whole molecular signaling pathways which are involved in these symptoms, in fatigue, in itching. And in that regard, we look at the wrong parameters, because if we take a blood draw, we look at liver function value, and liver function has not changed, and still the itching has become much worse. So many other factors influence itching, and so it should always be considered to figure out whether there could also be maybe a second disease causing itch, for example, if it's atypical in location, if it's different in character, and so on. So we always have to consider that as well. If we see suddenly changes in the skin, this is not typical. If it's, except for if we scratch a lot and then we have these scratch lesions and secondary changes in skin, but let's say this is not the case, and suddenly we see some rashes and papules and whatever, eczema, this should hint towards another disease which now is responsible for the itch. And in that, then the anti-itch medication by the hepatologist will not help. So this makes it a bit more complex, and should always be kept in mind that, you know, a PBC patient and an itch may not also necessarily be purely by the liver.
Yeah. Okay, perfect. That's helpful. Now, lots of questions coming in about doctors. So, as you know, many people are newly diagnosed. With the system being pushed as it is at the minute, it's not always easy to get follow-up consultations. So again, there's a lot of fear in terms of the doctor that they're seeing. Should they see a gastro or should they see a hepatologist? What is the difference? If they're not sure that the doctor they're seeing has the expertise they need, how do they go about being referred to a PBC specialist?
Yeah, I mean, the problem is normally, at least, let's say for countries like where I have been working previously, there is not a specialization towards hepatology. When you go to a specialist, you go to a gastroenterologist. The gastroenterologist will never state, I'm a hepatologist as well, because there is only the specialty gastroenterology and hepatology. So everybody should know it. But in the end, most of the gastroenterologists rather are focused on endoscopy, GI diseases, but not so much to the liver. The reason for that are mainly financial aspects, that you gain way more money by performing an endoscopy rather than taking some blood counts and
Oh,
taking
you cynic.
care. Yeah. So the problem is, how do I figure out now whether my colleague is a specialist in PBC? This is difficult because there are a significant number of gastroenterologists who know very well how to treat liver diseases. I think the easiest way to figure that out is to ask specific questions. And then you will see the reaction. If you say, for example, I have antimitochondrial antibodies, but I've read somewhere on PBC Foundation, but there are also anti-nuclear antibodies which can be associated with PBC. Then your physician should say eitherly rapidly, okay, yes, I know there are SP100 and GP110 and whatever. Then you know, okay, this guy really knows something about PBC. If that doesn't come out like this, then you should maybe reflect whether he knows the urso treatment, but then beyond other treatments may be limited. So it's a little bit of, you know, tell them, look, I have these symptoms. What can we do? I have read in the internet that there are drug developments for pruritus. So can you tell me anything about it? Or fatigue, or what do we know? How can we solve this issue? And you will recognize. And then if you say, if that is limited, or you have the impression that the input is limited, then you say, look, I know there are thousands of rare diseases, but maybe do you know maybe somebody who has more expertise, who sees 100 PBC patients, maybe who can have maybe help me in these specific questions, maybe a little bit more. And you of course, maybe you should stay with this gastroenterologist. If for the rest he does it very well, why not? But for specific additional things, you can get additional consultations once in a while.
Yeah, no, absolutely right. And so here's the thing that I often say, particularly people who are new to the foundation, and you've talked about general physicians and the fact that how many rare diseases are and all of those kind of things. I will always say to somebody that joins the foundation that if you do not know more about PBC than your clinician, then we've let you down as an organization. Because we have access to you, to Dave, to Palak, to Gideon, to all these people, Emma, Cynthia, who know amazing amounts of information. And if we're able to pass that on to the patient, then they should know more, certainly more than their GP, and often case more than a general gastro who is doing with many, many, many diseases. Now, in the main, for most patients, that in itself is not a bad thing because most patients respond to urso. Most patients sit within a relatively good area in terms of their symptom burden. And so most people are, I'm going to say simple, but their PBC is relatively simple to manage. And so having that relationship where you have a good gastro who doesn't know everything, but you are an informed, engaged patient and you're working together with that PBC can often be a successful setup.
I fully agree.
Okay. Ideal. All right. So I wanted just to provide that reassurance.
Yeah.
Right.
No.
I've missed Stephen's question now. There are lots of questions coming in, so bear with it. So Stephen, I did see it. I've just not had a chance to come to it yet. Okay. I am 2 years with PBC now, had fibroscan. I have fibrosis. We don't know which degree of fibrosis. The question is, I have joint and muscle pain and itch. Is this likely to continue and for how long?
So the question was now directed towards what symptom burden or?
Yeah, so they've got joint pain and bone pain, and they've got itch.
Yeah.
So, how long would he anticipate that is going to go on for?
Well, we are never sure about that. We see, these symptoms are fluctuating. They improve, they can worsen depending on external factors, on the weather, on temperature, on nutrition, on clothing, whatever. If you have arthralgia, I would certainly once consult a rheumatologist to exclude a real rheumatological disorder such as rheumatoid arthritis, for example, which is more common in PBC than in the general population, just to be ensured that this is not an additional disease which can be or should be treated differently from PBC.
Yeah.
There is not a specific treatment for the liver which will improve arthralgia. So it will be, treatment, symptomatic treatment, which should be taken to improve symptom burden.
Yeah.
For fatigue, for itching, sorry, I always have 3 questions. The first question is, tell me a number between 0 and 10, 0 meaning no itch at all, 10 the most bothersome imaginable pruritus you can think of, and tell me where you are. And then you can have roughly the estimation that we say if it's below 4, then it's mild, from 4 to 7 it's moderate, and 8 to 10 is severe. And if it's mild, I say take a topical ointment, topical treatments are in many cases sufficient. The second question is, is your sleep disturbed? So do you have problems falling asleep, or do you wake up because you're itching and then you cannot fall asleep anymore due to this agonizing itch at night, which is mostly worsened at night? Or if it's, just moderate to severe from intensity, then my third question would be, would you like to have this itch being treated? And if so, these are the three questions: intensity, sleep, and wish for treatment. And if this is a yes, then I would recommend to treat that itch. There are many treatment options, treatment ladders, anion exchange resins. We have fibrates. We have an antibiotic, rifampicin, which is also very efficacious. We have many other options which are all off-label use, except for the anion exchange resins. It has to be kept in mind, but still, in most patients, they are very safe. And in that regard, it depends a little bit how much you want to have it treated, but there are many treatment options these days.
Yeah. Okay. So we've got somebody saying that can't sleep due to itch, scale 8. So again, what I would say to you is let's arrange a call, let's talk, and let's, on a one-to-one with more detail, let's find out where you are and what we can do to help you.
Yeah.
Okay, there was another question. So there's been a shout out for nurse specialists who always have nothing but my respect. On that subject, I'm delighted to say we've got nurse specialists attending the summit this year, which is absolutely I'm delighted. Now, I did have one other question for you. We've had a lot of questions in today on Facebook, which is fantastic, but it's difficult for me to scroll up and down. Here we go. Right, bear with me. So the next question I have is in terms of somebody has seen a doctor, and there's lots of concerns in terms of not being able to get an appointment. Somebody was diagnosed 11 months ago. They were put on Urso 1 a day due to side effects. And again, if this is you, then I really, really think we should speak. So please get in touch with us directly. You can email us at info@pbcfoundation.org.uk. I'm about to write that email in the box. But if they're not able to see a clinician, if their clinician's not doing their labs or really listening to the patient, would you recommend that they go and find another clinician?
Of course. I mean, you should always think, this is my disease. I want the optimal treatment. There are many treatment options out there. And if you're not sufficiently treated or unhappy with that, please consider looking for another opinion.
Yeah. Okay. Thank you. What might well be the last question of the day? We are almost at 2 p.m. So you've tried Urso and you've not fully normalized. You've tried OCA as an additional therapy. And again, you're not normalizing your alk phos in your blood tests. To look at other medication, would you add something on or would you put something instead of?
Well, now this is going to be now very, very specific here. It depends. So let's say in such a situation, it depends, whether a person under a second line therapy has not normalized, means or can mean the AP is 130, just above the upper limit of normal, or it can be 350, which is way too high. So if it's 130, I think good treatment response. Whether we should really then aim to get it 10, 20 units further down to have it really normal, there is no clear data. If OCA is well tolerated, and if it's now very high, it's sure we need something else. And then the question would be, do we add something or do we replace something? And this depends on efficacy of the in-label second-line therapy and tolerance. If it's well tolerated, if it has reduced alkaline phosphatase, keep it at a fibrate in the real life setting, or consider a clinical trial. There are clinical trials out there addressing this specific issue. I think it's important to know that you're way better looked for in these clinical trials. And in that regard, always consider also clinical trials, because they are the optimal care you can get, and most likely a future treatment which is not yet available in the pharmacy. If the tolerance is not there for obeticholic acid, if you have significant pruritus, but alkaline phosphatase came down, I would also keep it, but treat the itch. Again, for example, with a fibrate or with rifampicin, these are the most efficacious drugs, and they also are efficacious in itch which is caused or worsened by obeticholic acid. If there's no benefit in laboratory parameters, then you can certainly wonder whether OCA makes sense, and then you should think about a switch. But keep in mind, OCA needs to be titrated 5 to 10 milligram, and it should be clearly reflected whether this was done, and so on. So there are many things you should really discuss with a specialist, actually, in these cases where we talk about second-line therapies or even triple therapies. There's real-life data out. It's not proven in clinical trials, only very early phase 2 trials, so very limited data. But certainly, if you require second-line therapy, the aim must also be to go as low as possible with your surrogate markers, in particular bilirubin and alkaline phosphatase.
Okay, thank you. Okay, I've been asked again to ask this question, so I'm going to throw it in there, Andreas, just for one more.
Yeah.
It's on your favorite topic. So the question is, what is Questran for? But within that, I'm also going to ask you to talk about the aspects of Questran that make it important to take it away from other medicines.
Right. So we have to be brief because I have another meeting, but the anion exchange resin interrupt the enterohepatic cycle. We know that the enterohepatic cycle, the bile coming from the liver goes to the gut and is reabsorbed in the terminal ileum in the end of the small bowel, and then via the bloodstream going back to the liver. If you interrupt that, itching is improved. We have not fully understand how that works, but cholestyramine does interrupt it. The efficacy is not very good, and that's why it's often not very efficacious. It has a horrible taste and so on. And as it binds biliary substances, it can also bind a lot of other substances, such as your medication you're taking. And in particular, bile acids, they are super easily bound. And if you take now urso closely with cholestyramine, all the urso will bind to this anion exchange resin and will end up in the toilet. This is then a very inefficacious therapy, and the same holds true for obeticholic acid and many other drugs. So 4 hours separation is ideal. I always recommend then to take cholestyramine before the dinner and 2 hours after dinner instead of the morning, and take all the urso in the morning, and then it's not a real problem. And most other drugs are also taken in the morning, so in that case this works best. But if after 2 weeks cholestyramine has not given you any significant benefit, really consider taking another medication.
Wonderful.
Okay.
Thank you so much, sir. Really good to see you. We will speak soon. Enjoy your next meeting.
Thank you very much. It was a pleasure.
Your time.
Thank you all over the world. Bye-bye.